Thank you for joining me for our third lecture in our vascular course for point of care ultrasound providers. We're going to be talking about pathology that we may encounter on our vascular ultrasound during point of care exams. So let's get started. Our objectives for today are to have the learner be able to identify numerous pathologies both inside and outside the vascular system, as well as recognize alterations in Doppler waveforms that indicate the presence of pathology, and describe how and why venous pathology is often caused by obstructive conditions, and recognize incidental pathology when encountered, and describe how to properly assess the findings for diagnosis, cause, and extent. So as we're going to talk about pathologies of the vascular system, we have to remember that the vascular system can't be treated like it's in a silo. So a lot of things that are occurring in the body outside the actual vessels themselves can really have a major impact on what we're seeing occur within the vessels. So one of the things when we're looking at the arterial side of our vascular system, some of the things that are going to have major impact would be heart disease. That would include myocardial infarctions, congenital heart failure, as well as tamponade. Now, within the the arteries themselves, we can have atherosclerosis. We will identify cases of atherosclerosis by seeing plaques, and those plaques can be calcified, fibrous, or lipid. We can identify actual aneurysms or dilatations of an artery. They're going to be typically in saccular, fusiform, or a pseudoaneurysm. And we can identify thrombus in the arterial side, even though that's going to be less common than on our venous side. In very serious conditions, we might find an arterial dissection. We can identify a coarctation or a carotid body tumor. So as we're looking at the arterial side, these are all things that are going to affect either the blood flow in the arterial side or actually be arterial pathologies in nature. So as we look at the venous side of our vascular system, most of the issues we're going to encounter are going to be really obstructive in nature or come from obstruction. So one of the main things we might come across is a compression of the venous system through some sort of outside mass, and that can cause a congestion of the venous system. We can also have thrombus that we're going to talk about, and then we can have congestive heart failure affect the venous side like it did with the arterial side, but this time, instead of a lack of output, it's going to be caused by the heart not getting rid of its blood and therefore being unable to take in more venous blood and backing up or obstructing the system. So these are some of the venous concerns we're going to be looking at. Now, a lot of our vascular system is going to be pretty superficial, and as we're scanning this superficial system, it's not uncommon to come across things that may not be vascular in nature, and yet you can't overlook them. So one of the main things, especially when scanning a carotid exam, would be to identify some incidental thyroid nodules. So we'll take a look at those. We can also come across inflamed lymph nodes, synovial cysts, most commonly Baker cyst in the popliteal region. We can run across lipomas, hematomas, abscesses, and this is just generalized soft tissue edema. So we're going to look at what each of those looks like so that you'll feel comfortable identifying and assessing those if you do come across them. Okay, so now that we discussed some of the causes of pathologies that we were going to look for, now we're going to kind of look at how each of those pathologies can affect what we see. So the first one we're going to look at is really myocardial infarction along with congestive heart failure. So while these are definitely different processes within the body, when it comes to how we visualize them on general vascular ultrasound, their appearances can be relatively similar. So both with myocardial infarction and with congestive heart failure, what we see is a decrease in the ejection fraction. So if you see up here in the right-hand corner, we have an echo. Now we're not going to cover echo really here, but I just use this example to kind of show how they're measuring for ejection fraction with an echocardiogram. So here it's looking at the left ventricle and the left atria in diastole, and they're taking basically a 3D volume measurement here, and then they're going to remeasure it in systole and then compare how much out of the total volume was ejection ejected during systole. So from that, they can determine how much the ejection fraction is. So we know with myocardial infarction and with congestive heart failure, we can expect that the ejection fraction is going to decrease. So it would be naive to think that that wouldn't transfer upstream and affect how the flow would look in the rest of our arterial system. So when we have a significant decrease in our ejection fraction, what we will see is a decrease in overall arterial flow. So if we look at this example, say right here, this is an aorta in long at the proximal aorta area, and during systole, if we have a good ejection fraction, that heart is squeezing hard and it is pushing that blood forward very forcefully, and so you see this really strong systolic upstroke here. And then as the heart goes into diastole, then it starts to relax and refill, and we see that that forward motion of blood in this aorta area is going to slow down to basically a stop and then be pushed back forward once the potential of those vessels kicks in and gives it another squeeze, and it'll continue that squeeze until our next round of systole. So this is kind of the same thing. This is just in the distal aorta, but you see this strong systolic upstroke that would be produced with a normal aorta and a normal heart. Now, contrary, up here, we're looking at a proximal aorta again, and yet this patient has very, very significant heart malfunction, or dysfunction. So here you can see during systole that heart is squeezing, but it's barely pushing any blood flow forward. And because there's such low pressure in the system, rather than that quick upstroke of a good strong squeeze, it is going to be kind of laggy or lazy. We call this a tardus parvus appearance. So because that heart's ejection fraction has decreased, the rest of the arterial system, you're going to see this kind of lazy, dampened type aortic, arterial Doppler form. So one of the key notes is when you see something like that, you can't assume right there that, oh my goodness, there's a problem in my artery right here. If your patient has significant impaired cardiac function, then you have to take that into account, and it makes it a little less clear whether this is truly arterial in nature or perhaps it's something coming from the heart. Another change that we can see, or another impact that can be had on our arterial system by our heart, is caused from tamponade. So tamponade, if you look in here, this is going to be the left ventricle right here, and you see this relatively good sized fluid collection here surrounding the heart in the pericardial sac. Now, if this fluid was pretty minimal, if it was just a little bit of a gathering of fluid, then we might call that a pericardial effusion. What changes it from pericardial effusion to tamponade is when the actual pressure of the fluid in the pericardium or pericardial sac is compressing the heart enough that that heart cannot get its normal ejection fraction. And so when this occurs, it's going to have a significant decrease in the heart's ability to pump through circulation. So because of that, you're again going to be seeing a decreased ejection fraction and all the things that we talked about that you would see with that in the other heart issues. Now, to get this particular image, again, we're not talking about echo here, but there is a very simple image that you can do, especially in a POCUS exam, where you use a transducer in transverse right at in the substernal space, and if you press very firmly in that region and angle your transducer superiorly towards the patient's head, you will typically get this long axis view of the heart, and you can easily pick up tamponade or pleural effusion in that image. Okay, now, so that's all the heart functions or heart issues that can really demonstrate changes downstream. Now we're going to look at the things that exist in the artery themselves that are causing changes. So the main or most common arterial pathology we're going to consider is going to be our atherosclerosis. So you guys know all the things that can lead to atherosclerosis we talked about in last week's lecture, especially in areas of bifurcation or disturbed flow. We can see atherosclerosis begin in its early stages. The thing to be aware of with atherosclerosis, especially if you're sending that patient to a surgeon or you're trying to classify it better for yourself, is that it can be classified by different terminology. So the first most common type of atherosclerosis I think we all have envisioned are these big, hard, calcified nodules or collections within the vessel themselves, and that would be a calcified atherosclerosis. Now, when we're looking at a calcified atherosclerosis, what we're going to see is a very echogenic leading edge, so it's going to be very bright in nature. And then because that echogenic or that calcified atherosclerosis is basically going to be reflecting all of my beam, there's no beam left to continue to gather information posterior behind it. So what happens is we end up with this great reflective echogenic area at the leading edge with posterior shadowing. So that would be very classic of a calcified atherosclerosis. Now, the less obvious atherosclerosis is going to be a fibrotic atherosclerosis. So this is kind of like an overzealous repair that may have occurred on the vessel wall, and it's going to be fibrous scar tissue, not so much calcification. And so these are going to be more subtle in nature. They're going to be less echogenic than our calcified here, of course, and they're going to appear often a lot more smooth. And when we see these, it's going to be really important that you have appropriate gain settings, meaning you don't have it too bright, you don't have it too dark, because you could easily darken these out and miss it. The other thing that's going to help you not miss these is making sure that anytime you suspect any type of atherosclerosis, that you're going to follow it up in long, and as you see here in transverse, where you see it again, and then in long with color. And if you see this having a disruption of color flow, then you know it's real, it's not artifactual in nature. So that would be an example of how a fibrous atherosclerosis would look. And then finally, and you might hear some people call these ulcerated atherosclerosis or an ulcerated plaque. The term that they're encouraging us to use more now is complex. So these are interesting little plaques, and they can have components of calcifications, they can have components of fibrotic areas, they can have broken vessels where they're actually bleeding. So they can have a very mixed appearance, and what exactly is in that complex atherosclerosis can be basically unknown by ultrasound or not very specific. So now we just describe it as complex. You'll also hear sometimes what they just talk about as a lipid stripe, and this would just be a thickening area of fat, which could be considered a type of atherosclerosis as well. It's going to have a very similar appearance to this fibrous change, might be a little bit more echogenic, but it shouldn't have the same kind of shadowing that we see here in the calcified. Now, when we do identify an atherosclerosis, most of the times these atherosclerosis won't necessarily be considered a major issue until they are what we say is hemodynamically significant. And most of the time for an atherosclerotic or a plaque area to be hemodynamically significant, it has to take up between 50 and 75% of the lumen of the vessel. Until they get to that point, most of the time our flow can compensate pretty well and we won't see a lot of Doppler changes. But once they bypass that point where they are hemodynamically significant, these measurements that we can take can really come in, become essential in identifying the percentage to which it is truly sclerosed, or stenosed, excuse me. So we talked about last week how you can use the velocities to determine the percentage of how much a vessel is stenosed. So if we look at this, it's going to be very essential in practicing good Doppler practices, setting your gait in the correct place, making sure that your angle is correct, making sure that your Doppler's angle is between 0 and 60, preferably 30 and 60, and taking all of those things so you're getting accurate velocities. Practicing all those good standards are going to help you image this and help you come up with a prediction, or at least know if this is somebody that is on the border and needs to go have a full scan. So when we find something that's a stenotic event or a stenosis, we want to document that area of the vessel in long and transverse with our B mode imaging. So we want to ensure that we're using adequate gain so that we're not hiding anything, and that we're not so high that we're actually creating artifact. So remember to do that. You turn up your gain and then taper it off until you feel like all the artifact is gone. We always look at things in planes that are 90 degrees to one another, meaning long and transverse, because artifact is so common in ultrasound that we can be tricked into believing something's there that isn't. And unless it exists in two planes, we can't determine with all certainty that it truly is there. So that's the first thing we're going to do. We're going to look at the area with the plaque in long and transverse in our B mode or black and white mode imaging. Then we're going to go ahead and turn our color on our long image, and we're going to do the same thing we did with our gain, but we're going to now take our color gain, turn it all the way up, and then taper off on it again until we feel like all artifact is gone. That's how we know we have the most sensitive color. Remember from last week's lecture, if we have something that's almost 100% occluded, between the difference between being 98% occluded and 100% occluded is major for the patient. At 100%, they won't go to surgery. So if there is any drip of flow going through that vessel, we want to make sure that we're identifying it. And in order to do that, we have to use our really most sensitive color, like I just talked about. You can also optimize that by turning down the scale, down the PRF. And if you're still having difficulty, you can always go to color mode rather than, power Doppler rather than color Doppler. Once you have all of your settings where you want them, you are parallel to the vessel, you've got your gate, you've got your Doppler angle, everything looks good. You're going to want to take a really good Doppler signal proximal to the stenosis. And what you're going to expect to see here is a pretty normal looking, a pretty high resistance looking waveform. It's coming up into a stenosis, which means the lumen is narrowing. And if the lumen is narrowing, there's less area for the blood to move through. So, pencil here. So my vessel's like so. I have a big stenosis here. Despite the best efforts of my body, I'm not going to be able to move the same amount of blood through the stenotic area that I'm able to move through this nice big lumen. So that is going to resist incoming blood flow. So what I'll see is a much higher resistance. So where I might have had a very low resistance waveform where I had good flow throughout diastole and so on and so forth, in this case, what I might see is a waveform that should look something like this, turn into something like this, where I have good systole. At diastole, my blood flow completely comes to a stop, and the resistance ahead is so major that it gets reversed and then gets pushed forward again. So incoming or proximal to my stenosis, I'm going to see something that looks like this, an increase in resistance over what I'm expecting. Now, when I get to the narrowest area of the stenosis, I'm going to expect to see something more like this. So what happens now is the resistance disappears. I'm in the stenosis and it's a free road ahead. So that resistance is gone. So I'm no longer going to have these diastolic reversals. But due to the law of continuity that we talked about last week, we need to move the blood through this space much faster so that we can try to maintain the same amount of flow. So you'll see here this very low resistance waveform, but you're going to see very high velocities. Now, once you get just beyond the stenosis, you're going to recognize a lot of turbulence. So this, you might have flow going forward, flow going backward. It's going to be very irregular, so don't be alarmed. So follow it down until the turbulence subsides a little bit, and then take another one. And this is where you should see it get to what's now going to be a lower resistance waveform with a tardus parvis upstroke again. Now this, again, we talked about tardus parvis being an issue when you had poor heart function because there wasn't enough blood maintaining that high back pressure, pushing that blood forward. Well, now it's not so much because of heart function, it's because we have this big stenosis stopping our blood flow from moving forward as efficiently, and so we see it moving slower to reach its maximum velocity. And if you do all these things together, what you'll ultimately, if you're so inclined, you can take the data to the charts and look at the vessel velocities for the particular vessel you're looking in, and it will allow you to classify percentage of stenosis by utilizing your highest velocity at the stenosis. So it could tell you, okay, you're 75 to 90% occluded because the stenosis, or because your velocities are in such and such range. So there's charts for that. You can take it if you're so inclined. Otherwise, it just documenting this and looking for those patterns that we were expecting near stenosis can make you more confident in your diagnosis of it truly being a stenosis. So last week we talked about aneurysms some, and so this is just going to be a quick review and then just a quick discussion on how we're going to treat an aneurysm when we do see it. So again, the different types of aneurysms are going to be saccular, as you see here, where it's an outpouching of a singular area. Fusiform, where it's generally dilated through a region. Now, if the whole artery is dilated, then we call it ectatic, but if just a region of it is dilated, then it's fusiform. Then we have our pseudoaneurysm, which really isn't an aneurysm at all, but it's been when there's been trauma of the vessel wall, so that vessel has leaked, and then the blood has been encapsulated, and yet so it can appear like an aneurysm, but really that wall is back intact, and it just has a pseudo appearance. When we see an aneurysm, it's going to be really important to follow all those protocols in B mode that we just talked about with your gain. You're also going to want to evaluate the aneurysmal area in long and transverse. And then you're also going to want to utilize your color flow. And you're going to want to assess the color flow in long and transverse. And this is, again, very important. What can happen when you have an aneurysm is that you have blood flow coming in, it becomes very turbulent, and then eventually it moves on. Well, because we have turbulence of blood, we're not moving blood through the system as quickly as typical. And so it can become a static event. And if you remember from last week, a static event is one of the 3 items in Virchow's triad that often leads to thrombus. So while thrombus is relatively uncommon on the arterial side, in aneurysms, that's going to be one of the most common places you're going to see them. So it's really important that we're looking with color in long and transverse, because what might look like an open aneurysmal lumen could actually be filled with thrombus that was difficult to see. And that'll be especially true on your larger patients where you're just not getting a beautiful, clear picture of their aorta in the first place. So once you've looked at it in long and transverse in B mode, and with color, then you're going to want to take your measurements. So when we're measuring an aneurysm, we're going to measure the length of the aneurysmal area. So I would set my calipers here, measure to here, and that would give me an overall length. Then in my AP image, so if I were to be looking at my aorta like so, I would measure the aorta proximal to the aneurysm. Sorry, I forgot to give this aorta an aneurysm. Okay, proximal to the aneurysm, at the largest area of the aneurysm, and distal to the aneurysm. So I have 3 measurements of what we call AP, or anterior to posterior. I have a length measurement, and then I'm going to turn and go back to transverse, and now I'm going to measure here in transverse, like so. I would measure at this level in transverse, like so, and then finally this level in transverse, like so. And that information is going to be really important if you intend to follow this aneurysm, because that's going to be what helps you determine if it's enlarging or if it's staying really stable. So that's classifying the type of the aneurysm, and then being able to measure it so that you can track it, or provide that information if they're going to follow up somewhere else. All of that is going to be incredibly useful for this patient. Now, as I mentioned on the artery side, we don't typically get thrombus, but in cases like this, you see this is an abdominal aneurysm, and you can see how it is filled with thrombus. So in this case, you can see the thrombus relatively well, but in lots of cases you cannot, and so having that color to kind of lead your eye to where the walls really are can be very helpful. The other thing that's going to be important if you're referring that patient somewhere else, or you want to get them one step ahead, it's always important to try and assess, especially with an abdominal aortic aneurysm, is to assess whether that aneurysm is suprarenal, includes the renal, or infrarenal, and that can be really useful information as the patient moves forward. Okay, so a couple more arterial pathologies we'll talk about really quickly. I know we mentioned dissection last week. So when we have dissection, that means that tunica intima has separated from the tunica media typically, and now it's going to create a true and a false lumen. So where our aorta once looked like this, that tunica intima is tearing, and over time, as that some blood is going to go down the true lumen and make it to its intended destination, but other blood is going to go down into this false lumen, or this blunt end sac basically, and over time as that pressure builds up, and can cause that dissection to extend farther and farther and farther. So that can happen almost instantaneously and lead to death, or it can be a little bit more gradual. So when we're looking for a dissection, again, you're going to evaluate that vessel in 2D or B mode, looking for an echogenic line that would indicate this tunica intima. So again, your settings are essential here. You've got to make sure that you're identifying it in long and in transverse to make sure it's truly there, not an artifact. And then you're going to follow up with color to identify which is the true lumen, which is the false lumen, and then of course get that patient off to surgery as quickly as possible. The other pathology that we can see, or really anomaly, is going to be coarctation. So coarctation of the aorta would hopefully be picked up in like a fetal ultrasound, but if somebody were to come to you later, a coarctation would of course be a significant narrowing of the vessel. So as you kind of see right here, so usually this is going to be towards the aortic arch, and so you'd have a normal looking aorta. All of a sudden this very narrow area or coarcted area of the aorta, and then back to a normal vessel. So because of this, what's going to happen is that heart is going to be pumping blood with lots of force into this proximal area, and then this is going to act like a very significant stenosis, even though it's not a plaque stenosis like we've talked about, but because it restricts the flow so significantly, it's going to act like a terrible stenosis. So what will often happen, and usually this will be picked up hopefully in utero, but that heart's going to have to pump so hard that it is going to lead to basically left heart enlargement, ultimately left ventricular hypertrophy, cardiomyopathy, and a number of different other issues. And so, but again, when you're looking at the Doppler signals, you would expect something that looked very much like a severe stenosis. And this could occur elsewhere in the body, which in the heart is where in that proximal aorta is really where we often talk about seeing this. So here you would see, if you were to take a Doppler signal right in this region, you would see this huge increase in velocities up to over 400 centimeters per second. And then post coarctation down in here, you would see this turbulent tardus parvis low resistance waveform, because there's just not enough blood there. So just a couple more things to be aware of. Okay, another thing that you can come across, this would be it's not technically within the artery, but it's so closely related, I did lump it in here with the arterial pathologies. But here would be a carotid body tumor, and so this is a vascular paraganglion tumor that usually occurs right in between the branches of the internal iliac and the internal carotid and external carotid arteries. So if you're assessing your patient, doing a quick screening of their carotid, as you come up and you see something having a major mass effect right in this region, odds are it's probably a carotid body tumor. If you put color on this is going to be hypervascular, so you'll see a lot of blood flow in this region. Other thing, differential diagnosis, it could maybe be a lymph node, but more than likely, if it's in this very specific location, it is probably going to be a carotid body tumor. The larger it gets, it can splay and move those vessels out. Because this is arterial system, those arteries aren't going to compress very easily because of their thickened tunica media. So most of the time, they're going to maintain their shape. However, these tumors can kind of grow around them sometimes. So definitely an important sort of incidental finding, or it could be affecting, if it is large enough, it is affecting the vascular system, it could be the culprit to what you're looking for. Okay, now on the venous side. So like I mentioned, venous pathologies are usually going to be obstructive in nature. So the first example would be like a compression of the venous system. So something that's having a mass effect or compressing or moving that vessel. So I grabbed this CT and you can see this very large mass here, and it is compressing this IVC significantly. And so if you're getting a congested IVC, from a surrounding mass, then of course you would identify that venous compression, but then you'd have to go look for the mass and what the mass was adhered to, or send the patient for other imaging studies. Another thing that can compress the veins of the abdomen and lower extremities is going to be cirrhosis. So, if you review quickly the hepatic blood flow, we know that we get about 25% of our liver flow from the hepatic artery off of the celiac axis that comes off of the aorta. The other blood flow is going to be coming through the portal. And so here's our portal vein. It's going to bring 75% of the blood. This is going to be oxygen deficient but nutrient rich because it is coming from those veins that, from the superior mesenteric veins, the splenic veins, veins that have resorbed a lot of nutrients from the intestines and delivered it to the liver. So if a patient has cirrhosis, what can happen is what does happen is it becomes very hard and it becomes very resistant to taking in this portal blood. And so a typical portal waveform is going to look something like this. And it's going to be very, a little bit phasic, forward continual motion. We also want to make sure when we're looking at this that you're going to use that color assessment, where if I have red toward my transducer and I am scanning the vessel coming straight at me, I need it to be red. If it's blue and I have a cirrhotic liver, that could indicate that I have hepatofugal flow, meaning I have portal vein flow that's going towards the feet, not towards the liver. And if that's the case, that would be a major sign of not just portal hypertension, but that the cirrhosis is so significant it's actually reversing blood flow. Now, once that occurs, if you're getting severe portal hypertension, or even if you're getting hepatofugal flow, then you're going to have a backup of all the veins that lead to that portal system. So your splenic vein is going to get backed up. Your superior mesenteric veins are going to get backed up. All of their tributaries are going to get backed up. And so it's going to cause this huge congestion event throughout the venous system. As that happens, we can get very congested, dilated veins throughout all of the abdomen, and it can lead to caput medusa, if you've heard of that, where the stomach begins to take on this appearance where the veins almost appear as Medusa's snakes. So that would be a very significant venous pathology that would be apparent probably by just clinically looking at the patient, but you would certainly see it on your vascular ultrasound. Congestive heart failure, it's because the heart is unable to eject enough blood flow out or adequate blood supply out, it's going to back up and get congested itself. And so because it's congested, it is not going to have the capacity to take incoming blood in. So the congestive heart failure will eventually congest all of the veins, like a cascading event, all of the veins feeding to it. Ultimately, because it can congest the hepatic veins that are so close to the right atria of the heart so significantly, those hepatic veins get congested, they congest the liver, and then they can even lead to, this can even be a cause that leads to cirrhosis and causes that cascading event to go even farther. So definitely congestive heart failure is going to have a significant impact on our venous system. So some things you might see with a patient that has a congested venous system is that it falls now into the category of that Virchow's triad, where we know that stasis falls into Virchow's triad as a significant causative factor of thrombus. So these patients with any type of these obstruction issues can be at higher risk for developing thrombus. So we talked quite a bit last week about how to identify a thrombus. We're going to look at them just a little bit more, but I just want to first draw your attention over here to something having a major mass effect on the IVC, which is going to cause it to dilate and be congested distal to that. Okay. So if we identify a thrombus, we know that thrombus appearance changes over time. So we have to be aware that they're not going to look the same every time. Like most things in ultrasound, for every pathology, it has a variety of appearances. So one of the key things in a thrombus that will always occur is if there's a thrombus present, even if we can't even see it, we should not be able to compress that vein. And so here you're going to see a very acute thrombus, and you almost don't even see anything within that vessel. You could chalk it up to just being an artifact. But you see here, once they've gone and tried to compress that popliteal, it wouldn't compress. So that is the true note that's gonna carry through on all thrombi. The other thing that's going to be common is if it's an occlusive thrombus, meaning it's not letting any flow by, it's going to cause proximal venous congestion. So if it's in the popliteal, I'm going to have congestion, in my calf veins, and they're going to get dilated, and then they're going to be more likely to develop a thrombus as well. So that again will occur with any obstructive thrombus. Now, the appearance of the thrombus, like I mentioned numerous times, is going to change over time. So a very early thrombus means that those blood coagulation events just began happening, the blood's thickened, it's created this thrombus, but it's not that organized yet. And at that point, it still appears pretty hypoechoic. As it develops and creates a more dense clot, then those echoes are going to become a little bit more echogenic. So it might be something kind of like you see in this area, although I would have to say in this particular one, I'm going to say this this second image here really falls into a late but resolving. So this is probably a mid to late. It's got very organized echoes here, and yet you're starting to see a breakdown of some of that thrombus in the center. So this looks more complex. It's later in the process, making it somewhat echogenic, and yet it's far enough along that thrombolytics maybe have kicked in and is starting to break down, and so you get both hypoechoic and hyperechoic areas within the same thrombus. Now, if this whole process is incomplete or fails completely, that's when you go to a late and chronic thrombus, and it's going to look like this. It becomes very echogenic, it's very well adhered, and oftentimes if it's occluding the vessel altogether, collaterals will be built, and the vessel will basically collapse around it. So those are some of the things that you're going to expect during a thrombus evaluation. So as I mentioned before, one of the most common things that you're going to find external to the vascular system when you're scanning are some of the incidental findings that we're going to talk about today. So because the vascular system is so superficial in some areas, we're really going to come across some things we're not expecting. So especially when you are scanning the carotid artery, you might be inclined to come across or identify a thyroid nodule. Really anywhere in the body, you can come across an inflamed lymph node. And then around joint spaces, especially around the knee joint, you're going to come in contact with synovial cysts, or in the knee joint or popliteal area, we call those the Baker cyst. So just to give you an idea of what some of these things are going to look like, you can see up here in our upper left corner, you see a thyroid gland here. And you can see that it's very homogeneous, kind of mid-level echoes. And then you can see this area that is very significantly different and yet encapsulated within the thyroid. So that would be indicative of an incidental thyroid nodule that you found that could trigger you to, send that patient on to more exams unrelated to the vascular system. When you're looking at this, especially with the thyroid, be aware that nodules can take on many, many, many different appearances. So basically, you get used to looking at what is homogeneous, as you see in this general region, and then hopefully your eyes will detect anything that is heterogeneous to the normal, and that would be something like this nodule here, this nodule here, which you may have to look a little bit more closely at. It looks like a thyroid nodule, but it could also be a parathyroid, so you'd have to see if that was really inside of the thyroid or external to it to make that differentiation. So it's not uncommon to come across these when you see that this is actually the carotid in transverse. You can see how when you're scanning that, you could most certainly run into something there in the thyroid. Now, here's where this sonographer turned on that thyroid and lengthened it out. And again, it demonstrates this area along with additional areas not viewed in this initial image. When it comes to inflamed lymph nodes, if we look down here, this is a pretty typical looking lymph node. They kind of blend into the background most often. Sometimes you'll kind of notice it being a little bit more defined than surrounding tissue or something like that. What is true of all lymph nodes is that they're really going to have kind of a little bit of a hypoechoic cortex with a echogenic or hyperechoic hilum, and that hilum will always have a little bit of blood flow. So if you come across something that looks like this and you see a nice little stream of blood flow coming into the hilum, then that's indicative that this is a lymph node and nothing else more alarming. Now, as lymph nodes get more inflamed, they get larger and more globular, so more rounded appearance than this bean-like shape. And then you can also see an increased color flow in the region of that hilum or hyperemia, indicating that there's some sort of infective process causing it to become have a higher need for blood flow. So lymph nodes, or lymphadenopathy, those are very common to find around the aorta, the IVC, in the inguinal area, definitely in the neck when you're scanning carotids. So a very common finding, and it's always reassuring to feel like you know what exactly you're seeing here. And then finally, a synovial cyst. Now, the classic features of a cyst would be well circumscribed, hypoechoic or black, with posterior enhancement or brightness behind the mass, and that would indicate that it was a very simple collection of fluid that would be mostly filled with serous, or in this case, synovial fluid. So if you see this in the popliteal area, sometimes you can see a track you can trace back to the actual synovial area of the joint space that is communicating with that cyst, providing the fluid into the cyst. So again, not an uncommon finding. Now, because this would be mainly filled with just synovial fluid, you wouldn't expect any major blood flow within the central portion of the mass. You might see a little blood flow to the capsule, but it's not going to have anything near the hyperemia that we see here in an inflamed lymph node. Some other findings that you might come across would be lipomas. These are really common in the arms and legs, and they can range from a little bit more echogenic to something that is actually pretty isoechoic to the surrounding tissue, such as this example here. The difference is that really when we're looking at adipose or fatty tissue or subcutaneous fat, most of the time it kind of blends in, as you can see up here, with other areas of fat, where with a lipoma you have it truly circumscribed. So this is an example of a lipoma that you can come across frequently. The next is a hematoma. So hematomas and abscesses can look relatively similar. So this happens to be a hematoma, or excuse me, this one happens to be an abscess. This one happens to be a hematoma. So you can see that they have some pretty similar complex type appearances. And so what's really going to help you with the differentiation between what this is going to be is that with that hematoma, usually are expecting that there was some recent trauma. With an abscess, it can be associated with a recent trauma, but not as directly. The other thing is with an abscess, because it's such an infective process, you're going to expect to see a fever or elevated white blood count or some of those systemic infections properties that you might expect with any type of major infection. Whereas with the hematoma, usually clinically, if it was significant enough, you might see a little bit of a drop in a hematocrit. A hematoma is going to act like blood, and so all the stages that we talked about that would occur with a thrombus are going to be true of the hematoma too. So as you can see, this particular hematoma, this is certainly not low-level echoes. It is certainly not consistent or homogeneous. It has some variation to it. So this is probably a slightly older hematoma going through some breakdown or thrombolysis of itself, and so it's leaving it with this kind of complex appearance. Oftentimes with hematoma, you will actually end up with a posterior shadowing, which can be helpful in differentiating this. Now, with an abscess, so an abscess can occur, with basically an infection that's gotten out of control in a particular area. Now, the abscess is filled not with blood, but now with purulent or pus material. The other thing that can happen here is when we have tissue that's breaking down, it can be releasing gas as part of the necrotic process. And so abscesses can have this purulent material. It can have serous fluid. It can also have areas of gas. And gas on ultrasound appears as what we call a dirty shadow. So that would be helpful in identifying if this was truly an abscess or not. But here you can see they'll have some variety of appearances based off of the cause, the inflammatory process or the infection. But ultimately, it can look something like this, and you're going to have to use your clinical background to go ahead and make the diagnosis from there. Some characteristics you will see about an abscess is you'll typically see hyperemia or a lot of blood flow in the surrounding encapsulation area of the hematoma because it's distributing lots of additional blood to that region to try and fight the infection. Whereas with a hematoma, you might find like one feeder vessel. So when we look at the blood flow on between the two different pathologies, you can see that those can also help you along with that clinical analysis to make your determination. And then here's something you'll come in contact with, especially, I know lots of times in a sonography department, we get orders for evaluation for DVT in a patient that has cellulitis. And so that they're very, very swollen. And we can pick up that soft tissue edema, and it looks like this, where you're actually seeing this fluid collection in between different tissues of the skin and adipose layers. And so this would be very classic appearance of what edema is going to look like. So hopefully you've gotten some ideas from this lecture on how you're going to look for pathology and what each type of pathology might look like and might mean. So in summary, basic point-of-care ultrasound, vascular ultrasound, can lead to the visualization of numerous pathologies both inside and outside the vascular system. Those arterial abnormalities that we're going to come across often lead to alterations in Doppler waveforms, so you have to be very knowledgeable about your Doppler waveforms and what causes them to change and what they should look like on a normal basis. Venous changes are typically caused by some sort of venous congestion. This can be primary when the congestion is coming from within the vein itself, or it could be secondary, such as congestive heart failure or a mass effect in which the venous system is being affected by something else. In either way, anything that leads to obstruction can lead to stasis, which is a key component in Virchow's triad, and can therefore increase the risk of thrombus. So when scanning the vascular system, we know that incidental pathology is often encountered, and we should be able to able to and prepared to properly assess it for diagnosis, cause, and extent, so you're able to treat your patient or move them on to the next steps. So hopefully you have found some of these pathologies that you may come across in the future and feel comfortable identifying them and describing them on ultrasound to help make your diagnosis process a little bit easier. Thanks for joining.